All right, so good morning and thank you to everyone for joining us. My name is Mike Talbot. I am Notre Dame International's Director for Initiatives in Mexico. Today is our third Mexico virtual lecture of this academic year, and it's presented by Notre Dame's Mexico Global Center. These lectures are really intended to highlight the work of our faculty in Mexico and with Mexican partners, as well as to deepen our community across the two countries. So thank you all for joining us today. Before we begin, just the usual prefatory remarks. Please keep your microphones muted. This will prevent background noises from interrupting the presentation. Feel free to turn on your camera if you'd like. It's always nice to see the audience, but we understand that in some circumstances that might not be possible. Also, feel free to submit any questions at any point during the presentation. You can use the chat feature at the bottom of the screen. You can also raise your virtual hand. I'll keep track of these questions so that Professor Reifenberg and Dr. Flores can address as many as time permits at the end of their presentation. Now to briefly introduce today's presenters. Steve Reifenberg is Associate Professor of the Practice of International Development and Co-Director of the Integration Lab at Notre Dame's Keough School of Global Affairs. Prior to joining the Notre Dame faculty in 2010, he worked for nearly 2 decades on international education, negotiation, and development issues at Harvard University. During that time, he served as Executive Director of Harvard's David Rockefeller Center for Latin American Studies, and he established the university's first ever university-wide office overseas in Santiago, Chile. Professor Reifenberg previously served as Program Director for Latin America with the Conflict Management Group and Director of the Edward S. Mason Program in Public Policy and Management, which is jointly administered by the Kennedy School of Government and the Harvard Institute for International Development. In addition to Professor Reifenberg, we are very excited to also have with us today a recent alum of Notre Dame's Masters in Global Affairs program, Dr. Hugo Flores. Dr. Flores is a physician and graduate of Tec de Monterrey's medical school here in Mexico. Prior to enrolling at Notre Dame, he co-founded and served as executive director of the Mexican branch of Partners in Health. He has collaborated with academic institutions in Mexico and the United States and has worked with the Mexican government to implement programs in primary care, mental health, women's health, chronic diseases, and surgery. Having graduated from Notre Dame this past spring, Dr. Flores is now serving as program manager with the Clinton Health Initiative's efforts in Guatemala. We are very excited to have Professor Reifenberg and Dr. Flores with us today. So with no further ado, please join me in welcoming them.
Great. Well, Mike, thank you very, very much. It's nice to see you, former colleague here at the Keough School of Global Affairs. Mike was in charge of the master's program in global affairs for a number of years. He was the founding program director now in Mexico. And I am absolutely delighted to be joined by Dr. Hugo Flores, who is really a central protagonist in the case I'm going to talk about this morning. And I'm really enthusiastic that he'll be kind of joining the conversation to really share some of his own experiences, having lived and worked for nearly a decade maybe more than a decade in Chiapas, and continuing to do global health work right now in Guatemala. So it is also wonderful to see, I get to see former students. I see, kind of current students, colleagues here at the Keough School. So nice to see a lot of friendly faces on the screen. Let me tell you what I think I'm going to try to do today. And we're going to talk specifically about this case out of Mexico, out of Chiapas, overcoming barriers to access where surgery is difficult. But what I thought I'd do is actually contextualize just a little bit both who I am and the kind of problems that I work on and other people here at the Keough School do. And then we're going to be talking through a case that was recently published by the Keough School, recognizing that people haven't read it. And when you teach a case class, a lot of times people have read it. And so we're gonna kind of do a modified version of a case class, assuming that people haven't read this, but thinking that there's really both an important story to tell here that's pretty interesting in and of itself, but also one that I'm going to argue there's some broader themes to thinking about development and making change in situations where it's very difficult to make change that can be drawn from this case. So that's a proposal. Maybe that between myself and Dr. Flores, we'll talk probably for about a half an hour, and then really look forward to having a conversation for the second half hour. Does that sound like a good plan, Mike? Okay, very good. So why don't I get started? I'm going to use this slide deck if I can make it work. So I just want to put up one slide about the place. This is actually the physical place I just came from, just teaching a few minutes ago with master students in something we call the integration lab. And the idea of the lab being both a space where people come together, collaboration, creativity, exploration, this idea of people from different disciplines coming together in a kind of structured program over the course of this master's degree, but really thinking a lot about collaboration, partnership, with the end to address complicated global problems. And the basic idea is so many of us get trained in one discipline. We get trained as a political scientist or as an economist or as a medical doctor or as an anthropologist or as a lawyer, but very rarely do we come into dialogue with other people from our disciplines or from our professions, particularly in an academic setting. And so this is one, and part of the reason I wanted to show the pictures is just how interactive this space is for thinking about the kind of complex global problems that we're dealing with. And I here just put a list of some of the kinds of issues that we deal with around inequality, the theme of today really looking at actually health, access and equal access to life-saving healthcare, refugee crisis, climate change, gender equality, food insecurity, social inclusion. And what I want to argue is that a lot of times people see that list and they feel this real tension. On one hand, what's one of the things that you feel is you feel almost overwhelmed. You see that list of just the enormous complexity, scope, overwhelming nature of these problems. How might I ever do anything about it? And so one is just this where would I even start? Another response, which sits exactly on the opposite end of the spectrum, is, oh, we've got to work, we've got to take action, we've got to move, we've got to go, we've got to do something right now. And sometimes people hear that response and then, what's the critique of that response? Well, it's not very well grounded in the real world. The savior complex, it's unrealistic. It might be delusional, it might be colonial, patronizing. And so then we get stuck. We get stuck in this tension, which is we talk about a fair amount between this overwhelming sense of the inability to do something on one hand, and the tension when we move to that space where we're going to try and act, move, go, do something, we're critiqued because you're trying to be the savior. There's a certain arrogance, this naive sense of do-goodism. And so what I want to do and use a specific case, this case from Mexico, is to explore the possibility of a different path. What might look like a path if we worked together, particularly with affected communities, to try to address a complicated problem. And I want to really center this conversation on a concept that we use a lot in the iLab, in the development field, increasingly is the language around accompaniment. And so I'm going to use this case a little bit to try to elucidate what would approach for a hard, complicated, difficult problem look if we took an accompaniment approach. What does that really look like in practice? And so, as I mentioned, with actually a undergraduate student here, Luke Maley, who's now graduate. He's now at the Mount Sinai Medical School in New York, but wrote together this case where surgery is difficult, overcoming barriers to access. And at the center of this case is situated this concept of accompaniment. And so again, that if I was teaching this class, I'd probably have the class read the case, we'd come together, and then we'd kind of try to work through this problem that's presented. And so I'm going to give you a little bit of the context for that problem, and then kind of have us maybe talk through, and with Dr. Flores here as well, a little bit, some of this approach, and reflect on the role that this concept of accompaniment plays in trying to approach this challenge. So many of you know, some of you Mexican on the call right now, but Chiapas is this remarkably beautiful, lush, verdant part, the southernmost part of Mexico. I've been there until COVID, had traveled there most summers, at least for some time, to interact with an organization called Compañeros en Salud, Partners in Health. Chiapas, here's a picture, the southernmost state in Mexico. Also one of the poorest states, 3 out of 4 people live below the poverty line. And so the story we want to tell is about the work of this organization, Compañeros en Salud, which is at the center of this case. And that really, if we imagine going back 15 years, you might see small concrete clinics like this that had been built in rural communities, maybe of villages of 1,000 or 2,000 people, that would be the primary medical care. But here's the problem. There's no doctors in this clinic. There's no nurses in this clinic. Or if they are, they're very episodic. Because what happens in Mexico, again, as many of our Mexican colleagues would know, is that much of the healthcare in rural Mexico is provided not by regular professional doctors, but actually by just graduated medical students in their very first year in what they call a pasantía, or they are called the pasante, the one who passes through. So it's a required year of service, typically in a difficult situation that everybody does to go on to become a formal, full-fledged doctor. The challenge in some parts, particularly rural parts of Mexico, this is a challenge all over the world, including here in the United States, is that it's hard to get doctors to go and stay in rural communities. And here's where the organization Compañeros en Salud comes in, which is looks at this problem, no doctors serving these communities at all, and really puts out a call at the best medical schools, both private and public, and says, we have this incredible opportunity and we want the very best doctors. It turns out that in Mexico, you get to choose your pasantía based on your GPA. People naturally go to urban centers, kind of more comfortable places if you've done well, typically, going down the list. And then there's a certain point of the list where there just aren't more people to go. Chiapas, and this part of Chiapas was one of those places. And so the organization puts out this call, invites doctors in, but does it in a kind of unique way. It says, look, if you will come, we will not just situate you alone in a isolated community, because we know what happens. Young people that go into those situations without much experience come out of it with like PTSD, post-traumatic stress disorder. It's been such a difficult experience. They're all alone. They're confronted with some incredibly difficult medical conditions that they've not been trained to treat. People are lining up outside and they're really overwhelmed. And so Compañeros en Salud says, come, we'll create a supportive community where we will help train you. We will build a community of other pasantes that will work together. We'll come and bring that group together in our headquarters once a month for a few days. And so suddenly it's not you alone in a rural community, it's you connected with other people that are in similar situations and with an organization. Secondarily, they also said, we're going to also build a community of people around you. We're going to call them acompañantes, community health workers, maybe a dozen in the local community, typically women. Often they don't have very high levels of education, but trained to go to people's homes, to check in on the conditions, particularly of the longer term problems that people have, and visit them regularly. And those people are a support network, acompañante to these pasantes. And so you're building this new network. And so what happens after a few years is actually they start getting these talented young doctors coming to Chiapas, working in these clinics, beginning to provide medical care to local people in ways that it hasn't happened before. And this is the point that this case kind of takes off. You have actually our protagonist in the case, who you can see there, a young doctor, Dr. Valeria Macias, who's having patients come into her clinic, and then some of these patients needing care much beyond what can be provided in the clinic. And that Dr. Macias writes them the kind of referral to go to the next level of care, which would be in a larger city where they would go and possibly they need an operation. They need something that can't be provided in a local primary care facility. And what happens is as she and her other pasantes are doing this, they begin to recognize that almost nobody that they're sending out is actually getting the care that they need. And the case begins with the story of one patient, Alicia. It's an older woman who has a uterus that is descended, who needs a hysterectomy. And she writes her the referral. A series of things need to happen for this referral to take place in terms of transportation, in terms of coordination of appointments, in terms of tests and other things. And each time, even though those steps are put into motion, it never happens. And so the case begins with the question of looking at it from the perspective of Alicia, of how hard this is. And just to move the case forward a little bit. So the question becomes, well, what makes this so hard? And so, well, what makes it so hard is this, it almost looks like a board game. It's actually based on the board game. But what you'll notice is this process map for a person like Alicia living in a rural community in Chiapas that needs a medical procedure, that needs to go to a larger city to get it. And look at how many different points, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Each one of those has to be a yes for this surgery to be complete. And what happens is that almost never are all of those sequentially a yes, that there's transportation, that you get the diagnosis you need, that you have the paperwork you need, that there's lodging provided, that the doctor, surgeon, and the anesthesiologist are there at the same time. And so what Dr. Macias and her other colleagues began to realize is nobody, but literally nobody that they're referring on to the next level of care. And these are under the Mexican Constitution, guaranteed rights that you have a right to access to this kind of healthcare, are actually receiving that healthcare. And so that's the problem that's kind of laid out for us as students thinking about that. And we begin to map what are some of these barriers. And actually a whole bunch of them, interestingly, have nothing to do with the medical care system, but they have to do with real people's lives. And so then the question becomes, what could you do? Both what is the problem you're trying to solve? How do you even define and conceptualize that problem? And what might you do? And the problem is fundamentally, nobody that's getting referred gets the care that they need. And so to kind of cut to the chase, if I talked about the initial impulse of Partners in Health to bring doctors to Chiapas and transform how they work with communities by building a community around them, by building these acompañantes that work with them. And I'm going to use the language of accompaniment here. So those young doctors are accompanied. The question then becomes, what does accompaniment look like in trying to solve the problem of Alicia and others' patients? And so the case kind of goes through a series of steps, first quite tentative, but about what would happen if you started, instead of just giving Alicia the paper and saying, here's the things you have to do, people started accompanying her through the process. And what's really interesting then, as you begin to accompany somebody, making sure that they have transportation, making sure that there's somebody at the medical center to receive them that's going to help them get the paperwork that they need, to calling ahead to make sure that the surgeon's going to be available on the same day to have the consult with the anesthesiologist. And Dr. Macias begins to reconceptualize her role from this local provider to somebody who's helping accompany Alicia and other patients through the system. And over time begins to build a team of people, actually a driver that when people need transportation can provide that transportation, a social worker that is part of the team. And every step of the way learning, and we begin to see people for the first time receiving the surgical and medical care that they need, and begin to get some real statistics and some data that suggests that this is actually pretty impactful. And then the really interesting part of this case, I think, and this is where the accompaniment moves from thinking, sometimes we think about it, this idea of walking together, an individual with an individual. But if you have somebody accompanying Alicia through this process and watching each of the ways we get by the stop sign and have a green light, but instead of thinking about it only as an individual walking with somebody else through this process, you begin to use that to reconceptualize the system. Where are the systemic barriers? How do we begin to address them? And so how does our accompaniment process of an individual shift to how we work as an organization, and ultimately how we think about this as a broader policy issue? And so they've made enormous gains over the last decade in terms of what has become the right to healthcare program, in terms of not just saying that there's a right to healthcare, but realizing in concrete terms that people in rural communities can get access to the care that they need. And so with that, by way of introduction of this case, I'm going to turn to ask Dr. Flores, who actually was the director, the founding director of Compañeros en Salud, worked very closely with Dr. Macias, who turns out to be the current executive director of Compañeros en Salud. And maybe that you could both add some nuance to the story that I've just told, or correct anything that I've got incorrect, but also kind of this model that I've been talking about of accompaniment and how it shapes this organization, Compañeros en Salud, its relationships with patients, and also the relationships with the state, thinking about how an organization like this might take the lessons that it's learning and then try to think about, well, how do we translate into broader policies that might have even larger impacts? So Hugo, could I turn over to you to just talk a little bit about your experiences in Chiapas and add to the story that I've just tried to tell?
Yeah, I think the concept of accompaniment is central in general in the right to healthcare program, because it depends. Accompaniment is a term that, over the past 10 or 12 years has become very prevalent everywhere. But I think it's one of those words that, because everyone is using it, it may be starting to, if not lose its meaning, but you ask, what does it mean if people are using it for very different terms? So I have been a very, very strong advocate of having a tight definition of accompaniment. And I definitely like definition by Paul Farmer, which is that accompaniment is the process in which you accompany someone, but the way in which you accompany is defined by the person you are accompanying, not by you, the accompanier. So, and I think this is central to how we generally think in Partners in Health, but also how we thought about the right to healthcare program. Because if the patient, you can only say you're accompanying the patient if you are responding to the patient's needs. So if the patient wants or expresses that they need transportation to get from their village to the hospital, you have to respond to that. If they need food, you have to respond to that. If they need lodging, if they need someone to be with them during the visit with the doctor, you have to respond to that. And also the length of accompaniment, and who defines when the accompaniment ends. It has to be always the person that is being accompanied. So in this case, we made sure that everyone, followed up with their treatment until they either got better or they decided that they didn't want to continue, which was very rare, but also happens. And in the case of many patients, this has been years and years of regular visits and support. And I think that's it. But responding to to the question, to the original question that Steve posed, this problem or this tension between not doing much and wanting to do things that are sometimes not very useful. The center of a company, the principle of accompaniment solves all of those problems, because what these two positions have in common is that they are focused around the self. They are focused about what I want or I think that should be done. Like if I am overwhelmed and I don't want to do anything because I have fallen into a cycle of cynicism or negativity, or this is what I want to do because I think I am so smart and I am great and I know the answer. But if you just relieve yourself from that burden altogether and say, okay, I really want to help. What do you want me to do? And this could be a patient, this could be the state, this could be an organization. This really could be anyone. And then most people that are facing a difficulty, or institutions that are facing a difficulty, will have a very clear understanding of what they need. So they will probably tell you what would be useful to do. And then of those things that would be useful, that are required, you can pick what is within your capacity to help with. Because when someone says like, well, I really need to build a new hospital and I need $50 million, but I cannot do that, right? But but some things you can do. And so I think that's a way that always brings both success and also satisfaction. And this is the thing, like asking patients what they want and see how we can help. And we really try to do it as much as we could, and trying to explore the different needs and trying to break down all the barriers that Steve showed in the diagram that were within our power to overcome. I don't know if that answers the question, Steve.
Yes, thank you. I think that's really, really helpful, and I concur, with the helpful, and part of the reason I was really interested in having you as part of this conversation, Hugo, is that you really have lived this work of accompaniment ever since we're at medical school, thinking about what does it mean to walk with patients, but also walk with young doctors, walk with the community health workers, walk in partnership with others, and building a kind of pathway forward. And I like how you said, between this vision of being overwhelmed and the I have all the answers, both of which are centered in the self, and really thinking about, well, if it's in proximity to others and walking with others, I have a really different lens on that. So I'm looking at the clock, and that's about a half an hour, which is what we said we would talk just for about a half an hour, and would love and could talk at length about a lot of things. We could talk more about the specific case and the work of Compañeros en Salud, talk more about accompaniment and its applications in different arenas. And actually something else at some point I'd love, Hugo, if you talk to us a little bit about, you've just recently finished the 2-year Master in Global Affairs program. You were actually chosen by your classmates to give the graduation address, I think, because they found you and your work so inspiring. And actually, as part of that, I started with my own work with the integration lab and working with teams of master's students. You had a really interesting experience working with the Harvard Medical School's program in global surgery and social change, and thinking about accompaniment maybe a bit more at a policy level, as how do governments in the Pacific Islands build out these national surgical plans that are going to help expand the access. For that, I see a Notre Dame graduate, Abby Noss, who's currently at the program in global surgery and social change on the call as well. So a lot of different directions I think we could go, but would love to just open it up to any questions. And Michael, if you could help us manage those, that would be terrific.
Of course, please, anyone who wants to ask a question, please put it in the chat or say you want to unmute your microphone and ask it directly. I can get us started. I feel like every lecture nowadays has to have the COVID question, right? So what you've described is a series of barriers to healthcare, which I presume is kind of the pre-COVID scenario. But of course, we know that under COVID, both treatment and access and diagnostics has been even more difficult for those in remote areas or more marginalized. Now, I'm imagining neither of you have been to Chiapas with all of the travel freezes, but from your colleagues there, have you gotten a sense about how this situation has, I would presume, been made more difficult over the past 2 years?
Yeah, and maybe Hugo, as a practicing medical doctor and someone very close to the situation, I'll ask you to start.
It has improved. I was in Chiapas last time. Well, I spent all my spare time with through the masters there, and I think my last time there was in May. Things have improved because I think we're at the point where hospitals are not overwhelmed with COVID patients, and everyone has gotten used to it. It's been a while since most of the, or all of the willing medical staff in Mexico are completely vaccinated, so, or health staff in general, not just medical. So right now, yeah, during the start, almost all the hospitalary services stopped because they were only focusing on COVID patients. And yes, a lot of patients really suffered from this. I think now it's getting better. And yeah, I mean, that was a problem all over the world, not just in Mexico. A lot of people who had like appointments, like got delayed forever, and many people died because of COVID as a situation, but not because of COVID as a disease, basically because they lost continuity of care. And this happened with patients that require some sort of surgeries, patients that had chronic diseases that couldn't attend follow-ups, the patients that had, for example, a lot of HIV patients like dropped their treatment. Like, it has really been terrible, and probably health systems have started to recover and to adapt to the reality that now COVID is just an endemic disease, so it just exists everywhere and will exist for the foreseeable future, and some people will be getting sick and dying of it. But I think health systems are becoming resilient. What really I think, but the COVID situation really talks about a level of accompaniment that is very the core of the School of Global Affairs, which is accompaniment at the level of international actors, both states and institutions, and this has been a complete failure. The lack of agreement regarding vaccine distribution, because the production has been there. Before COVID, the lack of cooperation to have systems in place to prevent a pandemic that, that everyone knew it was going to happen at some point, but that nobody really did anything about. I think this raises a question of now that we are a global community, that because of communications, because of supply chains, because of traveling, it's really not possible about thinking of countries in isolation. So what does accompaniment mean in global affairs at the global level? And we see what does this mean at the level of the World Health Organization? What does this mean at the level of the UN? What does this mean at the level of right now the COP26 with the climate change conference? I am living in Guatemala now, and what does this mean when the vice president of the US comes here to Guatemala to start a campaign of people, the Do Not Come campaign, trying to prevent migrants to go there, but at the same time, people here just facing extreme poverty, increasing due to climate change, et cetera, et cetera. And I think we have so COVID is not isolated from that, because I think COVID came to show that this is necessary and that the current institutions are not up to the task, right? And I would want to return this question to Steve, like, what is the role of a School of Global Affairs? And what is the role of an institution that is, important and relevant? And in tackling this, starting this conversation or starting to think about these issues.
Yeah, well, thank you. And thanks for Mike for the question about COVID and its impact, and Hugo for both your comments and the work that you continue to do in Chiapas and now in Guatemala. Two reflections. One is the first about the interconnectedness, COVID, like any pandemic, to see how interconnected the world is. And the corollary is how inequitable it is in terms of the response to something like this. And I think one thing the School of Global Affairs, but to all of us, to every one of us as individuals, as members of that interconnected community, is kind of a call to action, is a call for advocacy for, this is one of those things, we actually know what works, that people need to be vaccinated, and not just people in the United States getting booster shots, but actually the access to vaccines around the world. And so the access to the life-saving medical care that we know saves lives, and making that available, and figuring out strategies to do that. That's the first thing. And the second thing is when you talked about this, the language of isolation, which I think is just central, whether it's on the level of the nation state or of individuals. And for the longest time, I had on my wall right in front of me, as we were getting all this recommendations about what to do at the beginning of the COVID. I mean, we were still so unsure about everything, and it was so much language around physical distancing and masks. But physical distancing, so I had a little note on my wall, and it said physical distancing is not equal to social distancing. And so there is this reality of some of the things that you might have to do in terms of the spreading of pathogens that get people sick. But it's more than ever this necessity for social connectedness, kind of isolation. And many times, quite honestly, know this firsthand, that for young people so isolated, the incidence of suicide or other things like that it really takes lives, this isolation. And so that to remember that, in this case, physical distancing is not the same as social distancing, and that social connectedness is transformative. And that's what, so interestingly, like the language of accompaniment is that idea of proximity, of being connected. And the difference for somebody who does a lot of work in the field of development, and so much of what happens in development is kind of conceptualized in big offices in foreign lands and with groups that have resources, and projected as this benefit on groups far away. And there's oftentimes this huge gap between the reality of the perceptions of someone sitting in that office and what's really wanted, needed by communities on the ground. And the transformative nature of presence of proximity, of human connectedness. It's hard to get it as wrong as we sometimes do if you're living in the place that is the place that's to receive this support. And so that kind of, how do we think about addressing these issues around that isolation and inequality, I think are some of the central questions, whether School of Global Affair or any of us in our own lives trying to think about how to navigate these processes going forward.
Thank you both. I received a question here in the chat that says, so it seems to me that accompaniment requires great discipline and skill in the art of listening. Are there effective models that have grown out of the case study that helps us teach and foster listening on a large, systematic even scale?
Oh, I love that question. I think the listening is at the center of the accompaniment process. And I think the idea of generous listening. And one thing that I'm hugely heartened by is a number of medical schools and other institutions that now, instead of thinking about, oh, our job is to train people in technical skills that get, kind of levied or placed upon people to solve these medical problems. But this idea of like, I might have all the right technology in the world, but if I'm not listening to where this person is coming from, the reality of their circumstances, I can give them the best recipe in the world for what they need to do. But it might be so disconnected. It's like with the Alicia story. Oh, Alicia, here's a sheet of paper that's going to get you access to get a hysterectomy. There's no way in the world when you look at all those stop signs that was really going to happen. And the only way you're going to know that is actually listening, accompanying, walking with. And so I think that question that picks up on the centrality of listening to what are those barriers people are trying to overcome is really at the essence, I think, of this approach. And yeah, so Ugo, I don't know if you want to add to that.
Yeah, I think the accompaniment it definitely requires discipline, as you mentioned, Michael, because I think at every moment you have to make that decision in between what you want to do and or if you want to really, again, listen what the person or the institution needs. It's not because I worked there 10 years, but I think in terms of the scale, I think Partners in Health, to my knowledge, is an organization that really everything it does is through the lens of accompaniment. And because of that, it has been fiercely attacked many times by other big institutions, because there are, in terms of foreign, the industry of foreign aid, which is an industry, it has its own agendas and its own way of doing things that doesn't necessarily respond to the model, to the framework of a company, but it wants to still to impose things. But there are countries, and recently I had the fortune of having a conversation with the former Minister of Health of Costa Rica. And the system there, it seems to also have a model of accompaniment. So I think states can implement this when they decide to listen. And it's difficult when groups of people want different things. And I think this is when I think accompanying becomes complicated when there are opposite views of what is necessary. And it is also complicated when it hits resources, right? When resources that are competitive and that one group or person wants versus the others. And it also hits a complication when you as the accompagnateur, you know, have the question, how much do I want to give or I can give before I, you know, get myself, you know, destroyed basically. And this I think this is where accompaniment and it has a spiritual dimension, and that's why these conversations can occur in an institution like Notre Dame, but not anywhere else. But this is interesting. And I definitely don't know the answer to these problems. But at the end, accompaniment is always this decision or this dilemma between you and the other. And I think it becomes easier as this distance becomes closer. And the other way around. Recently, we celebrated the 10th year anniversary of Compañeros en Salud, and we had a very nice event. And one of the other founders, which is Dr. Dan Palazuelos, Mexican American, said something that was very true, that when we started doing this work in Chiapas with no resources and basically just, you know, living in tents, he said that the reason why we wanted to help these people more is because they were not our patients, they were our friends. Like, we were living at their homes, we were like eating with them at their tables, like we knew their children, with their families. So when that hits you, like, it's very easy to turn a patient away when you see them, you know, at your office, but it's very difficult to do the same with someone you're staying with at their house, and someone whose story you know. And I think this element of proximity can help solve these problems. When you see numbers, when you see, you know, X amount of people dying in a place that you don't know, that doesn't really have any response. But as Steve was saying, these problems can really get solved towards each other, towards listening to one another. Now, unfortunately, the system conspires against that all the time. We are isolated not just by COVID, but by distractions, and also we seek sometimes isolation because sometimes it is too much. And you know, this is the struggle, and this is, I think, the struggle at an individual level. But from an institutional perspective, we have to do the same. We have to make decisions that structurally favor proximity and disfavor isolation. For example, when one can ask, why is the headquarters of the UN, or why are they in New York City and not in Somalia, for example? Why are the headquarters of the WHO in Geneva and not in Chad? Like, this is the self-isolation that the system requires. I mean, it is absurd. And for example, one thing that I think has been very brave and game changer from Partners in Health is that Partners in Health country headquarters are in middle of nowhere, small towns everywhere where we work, except in Peru, because the work is in urban Lima, actually. But everywhere else, they are like in these places that don't even have like grocery stores sometimes. And it's not a secondary post, it's the place where the executive director lives. And I think this is what we have to start forcing ourselves and our institutions to do more and more, because then you start to see things differently automatically, and it works also in real time. Like, even if you have done that for a bit, if you then retract to again isolation, it's very easy to start forgetting again and to start seeing people as numbers. And you cannot accompany numbers, you can only accompany I would say real people. So to recapitulate, because I think went off too much. Yeah, accompaniment requires listening. Listening requires proximity, and proximity favors accompaniment, and it's a virtuous cycle.
Well, thank you, Hugo. And I was just going to add, Michael, that I think I'm glad you mentioned Partners in Health. I really see them as just an iconic organization that embodies and actually has really captured this language and idea and vision of accompaniment, and in ways that have been very, very powerful, and also thinking about their own work, as you described, the proximity in the towns and villages where they live and work, but also in terms of their relationship with government. They really, in the dozen countries they work, always try to work with government, see government as the agents of the states that ensure rights of the people. And if you want to think about scale, you've got to think about ways to engage government. And so how do we take the stories like of Chiapas and engage government to kind of write a broader, more ambitious, more visionary story about what does it look like if you really do this well, and how some relatively small changes can make a massive impact. And I think that that's a really exciting concept, and kind of the hope and aspiration of cases like these that tell what we think are inspirational stories, that you can draw broader lessons and think about, well, what would the applications look like in a place that I live and care about? And so there's the sharing of some of this information.
Thank you. So I've heard both of you talking about kind of accompaniment on two levels, right? One is the individual personal accompaniment, and the other is a more policy-oriented structural accompaniment across nations, governments, et cetera. And it seems to me the latter is kind of the international, the multilateral issues of vaccine distribution, et cetera. But I think it's really important, Hugo's comments about making sure that accompaniment is defined by the person who's being accompanied, right? That they have the agency and are defining themselves. So on that institutional policy level, how do you incorporate the perspectives or the voice of those who are in the other nations that are being accompanied, but maybe whose voices are not represented by their government, right? I mean, is there a way to balance that inclusion so that those who maybe are not represented by their government have a chance to define accompaniment as well?
I think that's a great question. The question always is who's sitting at the table, who's making these decisions and policies. And as Hugo said, it sounds like, an awful lot of the times they're made by a very select group in a very comfortable context, deciding for others. And I always think in these kind of contexts of somebody who's just so inspirational in this work, Father Gustavo Gutierrez. They often talk about the kind of father of liberation theology, a Peruvian priest who kind of spent a fair amount of time here at Notre Dame, but really kind of all of this language that we're talking about is very resonant with him and his work. But he was once in a conference and somebody was talking about their aspirations to be the voice for the voiceless. And he had them pause and he said, that's not our objective, is that you or I become the voice for the voiceless. It's to give them voice, to hand them a microphone, to shine the spotlight on them, and to find ways that bring those voices into these conversations, and not only in ways of intermediaries. And so it requires a really different way of thinking. And I think that it's a challenges a lot of the ways that organizations typically do things. And I think things as concrete and simple as what Hugo was describing, Partners in Health model of situating their headquarters, in not the capital cities, but in the places where actually they're doing the work. And that's a real transformative act that inevitably connects you much more closely with the people you're in communion with, working with, in community with.
Thank you very much for that. So we're coming up on an hour. It's nearly 1 p.m. here in Mexico and 2 p.m. in South Bend. So I just want to say thank you to both Professor Reifenberg and Dr. Flores for joining us today. I've really enjoyed, I think we've all really enjoyed this conversation, learning more about your work, the Integration Lab, the MGA, and of course, Partners in Health. So thank you for joining us.
Well, thank you. Michael,
Everyone.
thanks for organizing these conversations. I think it's a service to the office that you're really trying to reach out and make connections. And so we really appreciate it. And I also just wanted to add, if anybody's interested, the case that we've been referring to is available online through the Keough School for free for anybody who wants to see it. There also, even if you're interested, there are teaching notes and things like that that go along with it. So if anybody is interested in a case like that, you'd be welcome to get in touch with me or the Keough School and be happy to share that. Part of the interest is seeing stories like these that I really think are inspirational ones that kind of transform how we think about these, engaging on these kind of problems, and sharing some of the lessons, some of the struggles. And so if anybody's interested in that, I'd encourage you to take a look. And if you're interested in learning more, be happy to be in touch. So thanks again for the invite.
Okay. Thank you, everyone. Everyone have a great day. Thanks for joining us.
Okay, thanks. Bye-bye.